So today we'll first start with the hypothalamic pituitary component of PCOS. So first we'll talk about the normal reproductive physiology in case of females. So what happens is hypothalamus GnRH is produced. So these GnRH acts on pituitary. So from pituitary, gonadotropins are produced, that is LH and FSH. So this acts on what? This acts on ovaries to produce what? Which produce estrogen and progesterone. So next, moving on to the next slide, what is the problem in PCOS? So in PCOS, there is altered GnRH pulsatility. So this leading to what? This leading to increased pulse frequency of LH compared to FSH, thus leads to increased LH-FSH ratio. So now currently it is unknown whether hypothalamic pituitary dysfunction is the primary component in PCOS or the abnormal steroidal feedback. Now next we'll come to the long-term sequelae of PCOS. So first, as we know in the earlier session, we have talked about what is metabolic X syndrome. So the first consequence is metabolic X syndrome and cardiovascular disease. Number 2, increased chances of IGT, diabetes mellitus, as we know. Next is increased chances of endometrial hyperplasia and endometrial CA. Now since estrogen levels are increased, so increased risk of breast CA, ovarian CA. Next is obstructive sleep apnea because of insulin resistance and central obesity. Next is non-alcoholic steatohepatitis. Next is increased depression, mood swings, low quality of life. So these are all the long-term consequences. Next we'll summarize what are the hormones which gets increased and what are the hormones which are decreased. Now what are the things, as we know, what are the things which gets increased? So first is the LH levels are increased. Next estrogen, that is E1 is increased. Next is androgen levels are increased, that is testosterone, androstenedione, dehydroepiandrosterone sulfate, this is increasing. Next is insulin level rises and insulin like growth factor, and the bad cholesterol, that is LDL levels and triglycerides. So these are all the things which are increased. Now what are the things which get decreased? So first is the FSH, next is progesterone, next is sex hormone binding globulin, fourth is the good cholesterol, that is HDL, and apoprotein A1. So we have talked about pathophysiology, about the hormonal changes, about the long-term consequences. Now we'll go on to the treatment part. Before going to the treatment, we'll talk about the pregnancy complications which can also occur in a patient if a patient conceives with PCOS. So what are the things? So first is the abortion. And what is the risk? The risk is about 30 to 50% compared to general population, which are 15% risk. Now why does it occur? What is the cause? The cause can be insulin resistance, though the exact etiology is unknown. And to prevent this, we can use metformin, but we don't use it on regular basis. Why? Because this is a category B drug. We need more trials to use it for the purpose of prevention. Now next, what are the other complications which can occur? The other complications which can occur are PIH, there can be GDM, there can be IGT, there can be preterm labor, there can be increased perinatal mortality, increased chance of multifetal gestation because of use of ovulation inducing drugs, IVF, and again this multifetal gestation is also associated with many maternal and neonatal complications. Now moving on to the next slide. So what is the treatment? Now this treatment is very important. If you are into the private practice, many patients will come with complaints of irregular cycles, PCOS, and you have to be very clear while treating what exactly you want to treat, what is the severity of the disease, how it is affecting her life. So first we'll make a table and we'll see what is the complaint and what is the treatment. So before that, we have to know, for treatment we have to see what is the goal of patient, what is the goal, what the patient wants to achieve by the treatment, and what is the severity of the disease. Now the patient can have complaint of only irregular cycle, patient can have complaint of obesity, patient can have only insulin resistance, patient can have hirsutism, acne, and patient can have infertility. Now for obesity, our main treatment will be weight reduction and exercise. For this irregular cycle, our main treatment will be OCP. For insulin resistance, our treatment will be insulin sensitizer. The most commonly drug used is metformin. For hirsutism and infertility, we'll discuss it in details. Now next, how does obesity affects in PCOS? How is the obesity and what we can do? So the first conservative management is weight reduction and exercise. So if a patient comes and says, doctor, I am not able to get my cycles regularized, I am gaining lots of weight, what should I do? So your first advice should be, you have to reduce weight, you have to consume fast foods, you have to start exercising, and if you can't exercise, at least have brisk exercise for at least 10 to 15 minutes a day. And it's very easy. And again, only 5 to 7% of weight reduction can lead to 75% restoration of fertility. Therefore, you have to motivate her for weight reduction. Next, how does OCP helps in your PCOS hirsutism? Now OCP contains estrogen and it contains progesterone. Now progesterone does what? It decreases LH levels, and estrogen does what? It increases the hepatic synthesis of SHBG. Therefore, it decreases the free testosterone levels, and with decreased LH levels, there will be decreased ovarian androgen levels. Therefore, overall, there is decreased androgen levels. Therefore, we also use OCP for our hirsutism and acne. Now, which are the OCPs which are commonly used in hirsutism? So, the drugs containing the 4th generation progesterone, that is spironolactone, cyprotenon acetate, and what else? What are the other drugs which can use? We can use drospirenone. So why are you using this? Because these are anti-androgens. So as we know, with increase in the generation of progesterone, the level of androgen decreases. So the 3rd generation progesterone contains the least amount of androgens, while the 4th generation progesterones are all anti-androgens. Now, next, what are the other things which can use in hirsutism? We can use which are used are dexamethasone. Though we don't use it in our regular practice that often, but yes, they can be used, and you have to know for exam purpose. So what does it do? It decreases your DHEAS levels. And what is the dose? The dose is 0.25 milligram at HS, or you can also use at alternate days. Okay, next, what are the other drug which can use? Next is a ketoconazole. So what is the dose? The dose is 200 milligrams per day. What does it do? It inhibits what? It inhibits steroidogenic cytochromes, and thus decreasing the testosterone levels. Next, what else drug you can use? So this is an important drug. This is finasteride. What does it do? It inhibits 5-alpha reductase enzyme. Thus, it inhibits the conversion of testosterone to dihydrotestosterone. What is the dose? The dose is 5 milligram tablet. 5 milligram tablet is a daily dose. We can use it up to maximum 7.5 milligrams a day. What are the other use? It can be used for prostatic cancer. We can use it for BPH. Also, we use it for male pattern alopecia. So this is all. So this is about the treatment of medical management of hirsutism. Next is we can also use a topical cream, that is eflornithine hydrochloride. And how do you use it? We use it twice daily. For getting visible results, you have to use it for 4 to 8 weeks. But this is not a permanent solution. It does not permanently reduce the hair. Next, we have to know about what the permanent methods. This is another epilation. So the 4 techniques can be waxing, threading, electrolysis, and laser. So these are the permanent methods of hair removal. Now epilation does what? It removes the hair from shaft as well as the roots. Next, if a patient comes and says that, doctor, I am not able to conceive, I have done everything, I am walking, I am using I have done everything, but I am not able to reduce any weight, I have adopted a healthy lifestyle, I am having all the vegetables and all, but still I am not able to conceive, what can I do? So first you will say her for weight reduction, as you already tell her for weight reduction. Next is insulin sensitizer, that is metformin you can use. Next, another drug which is used in recent practice is myoinositol. Next is, if they are all failing, my metformin is as a ovulation is also used for ovulation induction drug, but the drug of choice is clomiphene citrate. So we'll tell in another class what is clomiphene citrate, what is the mechanism of action and all. For the time being, know that clomiphene citrate is a drug of choice for ovulation induction. And next, what is the last treatment? The last treatment is polycystic ovarian drilling. So this is a surgical option. So what does it do? Basically, what is the aim? It reduces the ovarian theca. So what happens in PCOS? There is increased LH levels, plus there is increased insulin levels. So it stimulates the theca cells. Causing it hypertrophy, and then androgen levels are raised. So with polycystic ovarian drilling, ovarian theca is damaged. What happens? What we do in this? What there is? So ovary is being punctured. So 10 to 15 punctures are done. And with a needle. What is the needle? What is the diameter of the needle? The diameter of the needle is 8 millimeter needle, and 10 to 15 punctures are done. With the electrocautery needle. Okay, and in 73% of cases there is 72% of conception rate. So this is all about the polycystic ovarian drilling. Next, we will know what are the advantage and what are the disadvantage. What is the advantage of this process? So since we are not using the ovulation induction drugs, so there is no risk of ovarian hyperstimulation syndrome. We'll talk in the next slide about what is ovarian hyperstimulation syndrome. But here, till the time being, we have to know that there is no risk of OHSS and multifetal gestation. Next, what is the disadvantage? The disadvantage can be adhesion formation, and with excessive of destruction of the ovarian theca, there can be premature ovarian failure and decrease of AMH levels. So what is the take-home message for all this ovarian PCOS and ovarian drilling? So we have to know that we are in a world where there is excess of medico-legal cases, excess of litigation cases. So before doing any kind of surgery or any kind of treatment, please inform and counsel your patient about what you are doing, why you are doing, and with your treatment, what can be the prognosis, what can be the advantage, what can be the disadvantage. So before going for ovarian drilling, please counsel the patient that yes, you have risk for premature ovarian failure, you can have decreased AMH levels. So you have to keep all these things in mind. And if you like this lecture, please like, share, comment, subscribe to my channel for the related contents, and tap on the notification icon for getting more notifications. So till then, goodbye. Thank you so much.